Hi, I'm Dr. Zachary Simmons. I direct the ALS Center at Penn State Health. And today I'm going to talk about telehealth to improve care and increase participation in research.
Hey, good morning.
Good morning.
Telehealth is a way to use technology
I can.
in a way that doesn't depersonalize our patients, but at the same time gives us an opportunity to extend care when they're unable to travel, either because of lack of resources or because of physical limitations.
We look gorgeous today, Cynthia.
So the program was presented to me by Susan Walsh. She's the registered nurse who runs the clinic at Hershey. The first appointment was January, and we have a lot of weather here in Northeast Pennsylvania, so it snows a lot, and she knew the travel was far, over 2 hours, so I agreed to that.
So place your nose clips on there and I'll talk you through it.
For the ALS team visit, which is the most common way we interact with patients, the goal is to simulate what happens when the patient comes in for a visit in our outpatient clinic.
Keep going, keep going, keep going.
With the only difference being that the patient is at home and we see them on a video monitor.
This part too, I think, is more.
I would agree with you. So telehealth for ALS is not common currently, and that's one of the reasons that I'm so excited about it. Right now, there are really only 2 other programs around the U.S. that are actively using telehealth to monitor and follow their patients. So in a sense, this has been really a groundbreaking effort to do something that we feel that people otherwise would not be exposed to. The goal is to provide us with another way in order to be there for them and to provide them with support.
Half the tablet, 2-1, at bedtime as needed. This is great. It just saves a lot of stress on my body. Traveling is nil. I don't even have to do the travel, so it's it's a godsend, really, for most. I'm sure it's going to help a lot of people.
So there's some terminology that I'll be using during this talk, and I just want to go through that briefly. Telemedicine typically refers to a remote clinician-patient interaction, and this is what most of us think of when we think of telemedicine. It's a typical video visit. The term telehealth is a broader topic, and it really refers to a provision of a broader range of services. So it could be collection of data on breathing function or on walking or on falling. People tend to call this video monitoring, but for the purposes of this talk, telehealth and telemedicine will be terms that I'll use interchangeably. In order to understand the value of telemedicine, it's best to understand what goes on in an ALS multidisciplinary clinic. And this will be familiar to most of you who are viewing this video, but in a typical ALS multidisciplinary clinic visit, patients are seen about every 3 months for evaluation by a multidisciplinary team. We perform pulmonary function tests at those visits. And we know that ALS multidisciplinary clinics extend survival and likely they improve quality of life. What about patients' perceptions of an ALS multidisciplinary clinic? Well, there are some positives and some negatives. The positives, according to a survey that we took on our patients a few years ago, was the integrated care, what some people called one-stop shopping, that the expertise of the telehealth providers, and that the patients had access to research and clinical trials. On the other hand, they did express their views about some negatives: the travel distance, the fact that the day was long and pretty exhausting, and that there was a long visit time and also a long wait time between visits with the various providers. So the goal of telemedicine in ALS care should be preserving the positives of the visit, but trying to remove some of the negatives of the visit. And we can do this in one of 3 ways. We can use telemedicine as a substitute for regularly scheduled visits with the multidisciplinary team, and that can be done, for example, for individuals who can't travel to the clinic. We could do it to decrease the length of an in-clinic visit. For example, patients could have one-on-one video conferencing with selected team members prior to the in-clinic visit, and this would reduce the time of the clinic visit itself. And then a third possibility would be to use telemedicine as needed for urgent matters. That would be, rather than seeing the whole team, the patient would have a one-to-one video conference with a selected team member depending on what their particular need was that time. So all of these are ways that telemedicine visits could be used to people's advantage. So based on these considerations, we've now incorporated ALS telemedicine fully into our ALS clinics in these roles. So I'd like to talk a little bit about a study that we did to look at the question as to how is it integrated into clinic and how valuable is it? So in this study, we got input from our ALS nursing staff regarding the burden that the travel posed to patients and their caregivers for the in-person visits. And then we offered ALS patients two types of telehealth visits into their homes using our on-demand system. One was that patients could have multidisciplinary clinics with members of the ALS team on clinic days. So this would be a full visit in place of their usual in-person visit. And the second was that we offered them one-to-one visits with individual ALS healthcare team members to address specific problems. And then we recorded the metrics. So what we found was that the average visit length was about 1 hour 43 minutes. The shortest visit was only 5 minutes, which of course would have been a visit simply to address a single problem. The longest visit was nearly 4 hours, which is sometimes as long as our in-person visits run. And there's a pie chart here which shows you a bit about the division of visits by time. And as you can see, visits ranged widely. The blue part of the pie is up to 60 minutes. The orange part is up to 2 hours. The gray part up to 3 hours, and the yellow part up to 4 hours. So visits ranged widely in terms of their time. How about the number of telemedicine visits? Well, at the time we did this study, we were conducting about 1/5 of our ALS clinic visits through telemedicine. Now it's settled out at about 25 to 30% of visits. So what determines the need for a telemedicine visit? Well, we did find that patients who live farthest away and those from more rural areas were overrepresented in the telemedicine versus the in-clinic group. And this is shown well in these two pie charts. If you look at the pie chart on the right, what you'll see is that only a very small percentage of people who were seen in person came from more than 100 miles away. And those are those two tiny little slices of the pie, each at 0.7%. If you look at the left side of the slide, which looks at telemedicine visits, you'll see that the people who lived farther away, either 150 miles, which is the gray slice, or 200 miles, which is the yellow slice, composed a much larger percentage of the patients that we saw. So in general, our telemedicine patients, not surprisingly, lived farther away. Telemedicine advantages individuals who have to make a very long ride into clinic. And this next slide, which shows a map of Pennsylvania, has two types of markers on it. The blue pins represent people who came for in-clinic visits, and the yellow and blue sort of drop-shaped markers represent people who did telemedicine. And as you can see, for example, near the top of the screen, most of the people who come from a really substantial distance from our clinic, which is that big red marker in the middle, were seen by telemedicine. But the people who are closer were mostly seen in person. But even looking at that, what you can see is that some people who lived quite close to the clinic did come to see us via telemedicine, because even when you're very close, if mobility is very limited, telemedicine may be a better option. So what did people think of telemedicine? Well, what patients and caregivers liked was they liked the absence of travel. They liked being in their home. They liked saving time. They found that they had less fatigue, and they were more comfortable. What didn't they like? Some of them thought it was sort of impersonal. Others had some difficulty with the video or audio portions of the connection. Some were concerned, interestingly enough, about what they called lack of privacy, meaning that if they were in clinic, they could literally ask their spouse or caregiver to exit the room, or we could ask them to exit the room so we could have private time with the patient. And that was much more awkward at home, either because it was hard for them to ask or because they needed the help of the caregiver in order to operate the equipment. What did they dislike? in addition to the technical problems, were that 4 caregivers expressed concerns about the lack of a physical examination, but interestingly enough, none of the patients did. What about the opinions of healthcare providers? So what they liked was patients seemed to be more comfortable, they seemed to be less stressed, and the healthcare providers liked the ability to see patients who would otherwise not be able to be seen. They also felt the patients were more open, more talkative, and they liked the fact they could observe them in their homes, which for some of our disciplines, for example, our therapists, is very important to see how people can get around or can't get around in their home. What the healthcare providers disliked were some of the same things that our patients disliked: problems with the video and audio, lack of physical examination, but they also didn't get the cues that they often get from body language because the camera was typically focused as a headshot, and some of them felt there was less of an emotional connection. But overall, it appeared that telemedicine was feasible and generally satisfaction was high. So on this next slide, I did talk a little bit about telehealth during the COVID-19 pandemic. And I think this is a good example of what happens when one has to use telemedicine in the extreme, that is for all of your visits. So all 127 ALS clinic visits were converted from telemedicine to, were converted from live visits to either telemedicine or telephone between March 18th and June 3rd, 2020. And we found that doing this, we were able to see almost 90% as many patients as we saw when we did in-clinic visits. On this slide, there's a pie chart that talks about patient preferences. In other words, when we had to conduct visits during the pandemic via telemedicine because people couldn't come in person, what did they want? And we found that about 90% wanted either a telemedicine or a telephone visit, but about 10% didn't want anything to do with those types of visits, and they just asked that their visit be postponed until they could be seen in person. And this pie chart here shows that well, that 62% of patients, and that's the piece of the pie at the bottom here, wanted a telemedicine visit and were able to conduct it successfully. Another 6% wanted a visit but couldn't have a successful telemedicine visit, so they had to default to telephone. And about 12% wanted a phone visit. So overall, 90% either telemedicine or telephone. When the actual visits took place, that is, when we weren't asking people what they wanted, but when we looked at what actually happened, because what one wants isn't always what happens, just because of technology sometimes, nearly 80% of our visits began as telemedicine visit, and of those, about 8% defaulted to telephone. So overall, about 70% of our visits were telemedicine during that time, were remote, either telemedicine or telephone. So what can be done via telemedicine? So the question that people often ask is, well, if I can't come in and I can't be examined, can you really do an adequate evaluation? And the answer is we can do an evaluation. It's just different than what's done in person. For example, we can tell how people are functioning by asking them questions on a scale called the ALS Functional Rating Scale, which we usually use in clinic anyhow. And people can report how they're doing in terms of walking, speech, swallowing, and so forth. We can do parts of the neurological examination. And while it's not the same, the parts we can do can be valuable. We can see if people can raise their arms above their head. We can take a look at how well they can move their hands. If needed, we can watch them walk. So we can do a number of parts of the examination remotely. We can get pulmonary function tests remotely, and I'll talk about that in just a few minutes. We can do a speech analysis remotely, and I'll talk about that. We can do cognitive testing remotely. We can test their memory and their thinking. Our psychologists can do an evaluation and do counseling remotely. And we can do a nutritional status and even possibly a weight check, depending upon the patient's access to a scale. So quite a bit can be done via telemedicine. So is telehealth as beneficial as in-person care? Remember earlier, we said that one of the benefits of multidisciplinary care is that it prolongs survival and it improves quality of life. Well, we don't know if telemedicine visits have those same two benefits. We do know that they can provide care. We do know that they're well accepted, and we do know that they are considered to be favorable by individuals with ALS and their caregivers. But when pressed, we really don't know whether the care that we give still prolongs survival and still improves quality of life in the same way. So that's a description of what most people think of as typical telemedicine, a video visit. But I also wanted to talk about how one can use telehealth to monitor and collect data. So the first thing I wanted to talk about was home monitoring of respiratory function through what we've called remote pulmonary function tests, or remote PFTs. So this was done with the collaboration of Dr. Andrew Geronimo, an engineer who works closely with our ALS clinic. And what we wanted to do was look at how the use of remote pulmonary function tests might impact on the decisions to recommend non-invasive ventilation, that is BiPAP, and similar devices to our patient. Remember that the guidelines recommend that a physician consider non-invasive ventilation, that is BiPAP or a similar device, if the forced vital capacity is less than 50% of predicted, or if the maximum inspiratory pressure is weaker than 60 centimeters of water. And pulmonary function tests are a routine part of the ALS clinic evaluation. Now, if one has telemedicine visits, then one of the challenges would be that if you then have to send people out to a facility to get their pulmonary function tests, that increases their burden and really undercuts the goal of producing care in the home. So what we wanted to do was to see if one obtained pulmonary function tests in the home, how did they compare to ones that are obtained in the clinic by the traditional respiratory therapy evaluation. So in this study, what we found is remarkably good agreement between a respiratory therapist doing a pulmonary function test and a patient doing a pulmonary function test in their home. The graph on the left here has two lines on it. The dotted line shows what you would get if there were perfect agreement between the two tests. The solid line, and along with it all the black dots, represent where the values actually fell, comparing the forced vital capacity by remote testing to a forced vital capacity by standard testing. And as you can see, the agreement is very close. They're really very good. And on the right, we saw the same thing for maximum inspiratory pressure. So not only can you do pulmonary function tests at home, but they're quite accurate. So the next step, of course, would be doing more frequent assessments of respiratory function using remote pulmonary function tests. And what I mean by this is shown on this slide with these three graphs on the left. That a 3-month interval for pulmonary function testing may not be ideal. As I show on the left here, ALS is a heterogeneous disease. The top graph shows people who progress very slowly. That means the curve of their forced vital capacity, their pulmonary function, declines, but it declines very slowly. The bottom graph is a group of patients whose decline was much faster. But yet, as I say on the right here, the clinic schedule is usually fixed. So most pulmonary function tests are performed once every 3 months while patients are in clinic. Perhaps it would be better to perform more frequent pulmonary function tests, and maybe that would let us initiate non-invasive ventilation sooner. And so we did a study to look at this question. Patients were asked to do pulmonary function tests in their homes weekly rather than once every 3 months when they came into clinic. And what we found is that they reached a level at where we would recommend non-invasive ventilation much sooner than would have occurred if we waited until their next clinic visit. In fact, the savings in time was a median of nearly 90 days. And so it turns out that home pulmonary function tests not only reduce burden, but they can result in much earlier initiation of non-invasive ventilation. And we know that non-invasive ventilation prolongs survival, so initiated earlier is better. There was a study that was done recently in Ireland where they looked at their experience with home pulmonary function testing during the COVID-19 pandemic. Now, they found that patients were very satisfied with them, but they did find when they asked people how often would you agree to keep doing this at home, not everybody was thrilled with the idea of doing it weekly. The most popular choice was once a month. As I said, in our test, we did it weekly to get such good advantage of it in terms of starting non-invasive ventilation. But it's difficult to tell. Perhaps if we had a discussion with patients and let them know that the advantages of doing it so frequently are substantial, we might get good buy-in to doing the testing more frequently. So I wanted to talk a bit about gait and falls, which is another way of home monitoring. So as background, patients with ALS fall, unfortunately, and the consequences can be profound. If people have limited mobility and through a fall they injure themselves and they're forced to be even less mobile, that can have profound consequences in terms of their eventually getting back to being mobile, and also severe consequences in terms of other complications of being sedentary. So the assessment of a person's fall risk and being able to prevent or at least reduce the frequency of falls would be very important. So how do we do that now? Well, now assessment of gait occurs in ALS clinic about once every 3 months by the physical therapist. The question is, can we do a little better? Can we pick up people's changes in walking earlier and maybe do something to prevent a fall rather than only seeing them once every 3 months? So we've done a study, and we are still doing some parts of this study, where patients wear what we call activity sensors on their neck or on their wrist, and they wear them for 48 weeks. And the recordings on these sensors tell us much about the patient's movement, about their stability. And we're looking for patterns to see if the recordings that we get on these sensors can alert us to changes in their walking and changes in their balance that would indicate a higher risk of falls. If we can identify changes through these sensors that would indicate a higher risk of falls, then we could ask people who we were concerned about to wear the sensors once a month or wear them once a week for a day, and we could try to determine whether their walking was changing in such a way that they're now at higher risk for falls. Then we could initiate something before they fell, have them seen by our therapist, maybe recommend a walker, perhaps recommend a brace. There could be different outcomes. Another way that we can monitor people in their homes is that we can monitor speech and swallowing. And so as I say in the slide here, we're in the process of doing a 6-month study to identify and track Bulbar progression, that means speech and swallowing progression, via smartphone-based self-administered remote speech and swallowing assessment. So what that means in English is what we do is we have the person speak into a microphone connected to their smartphone, and then they transmit the speech where we have it analyzed. And there's specific analysis programs that look at voice patterns. And what we are doing is we're looking for early changes in speech that might indicate that we need to intervene, or early changes in speech that might be a warning for us to tell the patient we need to see you a little sooner because we're concerned about changes in your speech. The graph that's below that smartphone photo shows that the number of times a person swallows per minute, as measured by the microphone, is related to the severity of the difficulty they have swallowing. So if they wear the microphone for a while and the smartphone records how many times they swallow per minute, that can also tell us quite a bit about their bulbar function, and again, allow us to potentially intervene before they get into trouble. There's a system that I've put up on this slide here called the TIM system, which was developed in the UK as an app for a tablet computer. And what's done there is that patients and their caregivers get weekly questions, which they answer on the tablet, related to their limb function, their bulbar function, their nutrition, their respiratory function, and their overall well-being. Caregivers also communicate via this system about their strain, depression, or anxiety. And then the system can record weight using Wi-Fi enabled scales. And so what the individuals who are doing this work have found is this is a great way for individuals to communicate to clinicians who can then display that information and track it in a useful way to permit better care. A very similar system was tried in Europe called the ALS Home Monitoring and Coaching System, which again was an app that goes typically on a patient's smartphone. It was designed in collaboration by patients and healthcare professionals. And the key features are that there's a self-monitoring app, so people enter questions about they enter answers to questions about their welfare and how they're doing. There's a message function where the patient can contact the healthcare professional or vice versa. There are alerts so that when people fall below certain warning points, like their weight declines too much, for example, a message is sent to the healthcare providers to alert them, they can then contact the patient. And a nurse practitioner follows up periodically. So for those who are comfortable with the technology, this is a really good way to keep in touch with their healthcare provider with greater frequency. And then finally, telemedicine can facilitate clinical trials research. And so I talked a little bit before about studies that we are doing that involve using telemedicine to record features about patients and help us intervene earlier. But telemedicine can also facilitate research into new medications, into clinical trials. And the reason it can do that is because telemedicine can facilitate recruitment, which can be done online. It can facilitate consenting, which can be done remotely. We can do assessments, as I mentioned before. We can look at speech, we can look at swallowing, we can look at ALS functional rating scale score remotely. And the need for some in-person visits remains, but because physical examinations do eventually need to be done on our patients, but the number of visits can be reduced and the burden on our patients can be decreased. What are the barriers to telemedicine? Well, there are still a number of them. One of them is the comfort level of patients and caregivers with the technology. Some people are much more comfortable with technological solutions than others. Some areas have limited broadband connectivity. There are reimbursement barriers. Because of COVID, Medicare changed the rules and allowed more liberal reimbursements for telemedicine visits, but it's not clear whether that will be sustained. There are limits on practicing across state lines. Many of these were also lifted during COVID, allowing a physician in one state to provide telemedicine services to people in another state, but whether those limits will stay is not clear. Only some outcomes are accepted as valid for research use. So there's a lot of things we can collect, but the other question is, what will the FDA accept as really showing that a drug works or doesn't work? And then this is a bit of a philosophical question. So I ask, how much in-person contact do we wish to give up? In other words, the human contact between physicians and their patients is meaningful. The contact between patients and the research coordinators is meaningful. And I think we have to ask, how much of that are we all comfortable sacrificing? So where are we going? So telemedicine visits, I think overall can supplement, but at this point certainly can't replace in-person care. The physical examinations aren't the same. The connection is not quite the same. We do not see any of our new ALS patients via telemedicine. We see them all at least one time in person. Remote monitoring can improve follow-up care and safety. Patients and their healthcare providers need to determine the balance between in-person and telehealth, and that balance will be different for each provider and for each individual with ALS. We need to find what works for our patients. And then lastly, for research, telemedicine can increase opportunities to participate, but some in-person visits are still going to be needed. So that's all I wanted to say today, and I really appreciate being invited to talk today, and thank you for being here.